My name is Jillian Mason.
My name is Benjamin Day.
And this is the Medicare for All podcast, the podcast for everyone who needs healthcare, with very few exceptions.
Yeah, and the podcast for everyone who needs better audiovisual setups for podcast recording.
Yeah.
I come to you today from possibly the worst audiovisual setup I've ever had in the history of this podcast.
We'll leave that for our listeners. We'll put up a poll if you want to vote on which is the worst setup that Ben's had. That would be great. So we apologize for a little bit of a shitty sound quality on Ben's end. I would like to blame him, but unfortunately, it probably isn't his fault. But we promise you, we're going to get this straightened out for next time. But we couldn't let a week go by or a bi-weekly whatever go by without bringing you a new episode. So,
yeah. We have a long-term relationship with our streaming platform, but it started to feel like an abusive relationship. I'm thinking about seeing other people. I don't know about you.
That's a thing that might happen for sure. Absolutely. But anyway, regardless, we got a really good show for you all today. I'm going to be talking a little bit later with Dr. Diljeet Singh from the Physicians for a National Health Program about moral injury in doctors, which is super depressing, but really important. It's all about how, doctors suffer a lot of trauma from knowing exactly the right thing to do and being prevented from doing it in our healthcare system. So folks will hear all about that later. But for now, how are you doing this week, Ben? How are things?
I'm doing good. I do not do great with heat waves. I'm not a heat person.
Yes.
So, but aside from that, I'm all right. How about you? How's it been there in Texas?
I keep forgetting that y'all have a heat wave going because we just have a permanent heat condition.
It's Your life is a heat wave.
It's not a wave; it's more of a tide that goes up and down regularly. So I am very sorry to folks in the Northeast and I think in the Midwest too, who are now in record heat waves. How are you handling that, Ben? What are you doing?
We were up in the hundreds quite a few days over this past week. So obviously, the problem is we have air conditioning up here in my office, so that's fine. I can work, but I can't do anything after work ends. We don't have air conditioning downstairs, so I just enter kind of a sluggish coma state. My poor dog doesn't want to go on dog walks. He only wants to walk directly to a pond and swim in it and then go home. And that's our life these days. So,
actually,
great.
That sounds really nice. And I'm really happy that you're getting a taste of our slower Southern, way of life.
This must be how it happens.
This is why it's so slow, for real. Here in Corpus, we're doing okay. We had an event. Folks who are regular listeners might remember that we did an episode about the fact that Corpus Christi is running out of water. I mention it as often as possible because not everyone who needs to know about it knows about it. But we have recently had some rain. And so our just sublime city government decided to have an event that basically was a prayer event to thank God for bringing us rain so that we could stave off the water crisis for approximately 3 months.
I thought historically it would be better to pray before the rain and not after the rain, but that's an interesting theory of change.
It's a theory. It is. It's a theory of change. And it's pretty crazy. I think it might have been better to get together and pray for some of our city leadership to be removed, but hey, whatever. But we got a lot going on with healthcare news this week, and I want to talk about it. I want to tell you all about it. The first thing is about our good friend, the ACA, aka the Affordable Care Act, aka Obamacare, aka Romney Care if you're in Massachusetts, because he did reluctantly sign that into effect. So the ACA marketplaces are not doing so great, Ben, because of some of those premium increases for 2027. You might remember those. So right now, there is, the 2026, sorry, the 2026 premiums increased, and we've already seen a drop off because of that. But we are also going to see a median 14% premium increase for 2027. I'm not great at math, Ben, but that adds up to something I can't afford.
And if I recall, last year it was an average 18% proposal, because we're just at the proposal phase. They're like submitting to the government what they think their increases will be. And then it ended up being a 20% increase. So I don't know. When you string together a couple of years like this, it's like suddenly healthcare costs have gone up by a third or a half over just a very short period of time. It's just nutballs.
What's the difference between a mean and a median again, Ben?
Yeah, so the median means that it could be much worse for a lot of these plans. The mean is the average, and then the median is just the one in the middle. So that means it could be hiding just extraordinarily high premium increases at the top. So
there we go. And that explains the experiences I've been hearing a lot about. I mean, we know that a lot of folks saw 100 to 200% increases. I think I had a 100% increase in my premium this year. Healthcare now provides me with healthcare. I just want to state that for the record. But we do buy my insurance off of the ACA marketplace. Let me say, it's not my favorite health insurance that I've ever had either, but it is the most expensive. So there we go. So this is going to be a really, really big issue, right? Basically, even though when those subsidies expired and premiums went up in 2026, right? The enrollment in the ACA plans, it actually fell from 22.1 million to 19.2 million, right? So that's a substantial number of people who have lost their health care. And so the insurance companies are now claiming that increasing hospital costs and prescription drug costs, and of course, people using too much health care, which is always a funny accusation, et cetera, et cetera. And they also are citing the fact that they have a sicker remaining risk pool, because people who are sick are not going to get off their health insurance as easily. What a shame for them. So anyway, in Ohio, they've got the largest percentage of the enrollment drop, like 32% of people in Ohio who were on ACA marketplace insurance actually lost their coverage. So this is something that is impacting everyone. How are you feeling about that, Ben?
Well, I'm glad I'm not on the ACA marketplace anymore, but I have a suspicion. I mean, whenever you get these stories, you get like the laundry list that you just kind of repeated of possible causes. It's like prescription drug costs, hospital costs, general inflation. There's labor shortages. There's, people leaving the marketplace who are healthier, and so the pool gets more expensive, and so on and so on and so forth. And you never really know which ones are the most important. My guess would be that probably the underlying healthcare costs of hospitals and prescription drugs is the most important. And if that is the case, that means that the rest of the country is going to get hit by similar news about a month or two from now. Because, employer-sponsored healthcare, employers don't get the news, I think, until like August or months later. You start hearing about the premium you're going to have to pay for 2027. So don't be shocked if the rest of us are hit by this. And it is weird in that, only the employers see that terrible, horrible news. In the most part, if you're a normal worker, you're probably not going to see this massive increase. all you're going to see is that your employer is not going to give you pay increases year after
Right,
year
or
after
your
year after
hours.
year after year. Yeah.
Your hours are going to get cut back, there are going to be, lots of consequences. And we talked a little bit, I think, on 2 episodes ago about how employer-based plans have been some of the hardest hit, actually, by premium increases this year. And a lot of employers don't have a choice but to push them onto workers. Of course, there are plenty of large employers like the Walmarts of the world, right, that could definitely afford to provide their employees with plenty of healthcare if they felt like it. But for like small businesses and stuff like that, they are really going to be forced into making some tough choices.
Yeah, and I would also rush to point out, I'm sure a lot of this is just inflation, which is affecting everything. Do you recall the good old days when Trump was running against Biden, and Biden basically lost this election or had to drop out, probably because of inflation, I think. It was like kind of the number one thing, and Trump's is like, I'm going to fix this solution. Not so much. Probably all the tariffs are playing in to some of these costs as well. So yeah, it's really just because we see it not just in healthcare costs, but also in housing and the cost of food and
the grocery store, gas, all the shit. Absolutely. My guess though is that this is going to come back to if you recall the last report that we talked about with the employer-based plans, right? That they were really pinning it on GLP-1s.
That's convenient, right?
My sense is that us fat people are going to take a lot of the blame for this. I don't know. Preliminarily, I guess on behalf of the fats, I would like to say, screw you all. This is not because of us. It's because the prescription drug companies want to make $1 billion off of a drug that was mostly produced through research and development funded by our tax dollars. So, coolio.
Our very old diabetes drugs.
Right, exactly. All right, we're going to go back to that in 1 second, but I did want to touch on, actually, let's launch right into that now. So the GLP-1s, all these different, providers are balancing the fact that people really want GLP-1s, right? And the fact that they are incredibly expensive. But they don't want to pay for them. Yeah. Okay. So that's the main issue. That being said, it's kind of a cool thing that's happening right now is that Medicare has actually started a GLP-1 bridge program. So the way that this works in most insurance and the way that it has worked in Medicare, and we touched on this before, but I want to sort of just go into it a little bit, is that GLP-1 drugs, which includes Ozempic and Zepbound and Wegovy and all of those quote unquote miracle weight loss drugs that you've heard of. And they are, they're really, really expensive. Insurance companies generally do not cover them for weight loss, which is interesting because I think probably most of you know about them as weight loss drugs, right? That's how they're advertised on TV. That is how they, really market themselves. That's how you hear about them in the media, right? You see the celebrity who's just lost 1 million pounds and they're like on Ozempic, right? So that's the experience that most people have in their minds. But in actuality, insurance will not cover GLP-1s, including Ozempic, for weight loss. They'll cover it for your diabetes. They'll cover it for your A1C issues, but they won't cover it for weight loss. And Medicare has been the same arrangement. That is the thing that's driving so many of us into, and myself included, into the very, very shady market of online compounded pharmacies. So I get I pay $300 a month to get a vial of non-branded Ozempic sent to my house. And they send me a couple little syringes. And they're like, go to it, you know?
Fabulous.
Go to it. It's like almost impossible to find out what the actual concentration of the drug that I'm using is.
Right.
It's supplemented with all sorts of crazy vitamin shit, B12, etc. And so I have, for the longest time, I've had no idea actually how much of this drug that I'm taking, but my doctor really recommended it and wanted me to be on it. And so I am paying $300 out of pocket every month. Sucks. Medicare is actually, they've created this bridge program now, though, where they're making GLP-1s available for $50 a month for certain weight loss patients.
Okay. Yeah, I mean, proving that Medicare is better than private insurance. And, just bear in mind, forever we've been trying to get Medicare to negotiate all its drug prices.
That's right.
And I think it can now negotiate some. And if GLP-1s became, one of the biggest cost drivers, then obviously Medicare would be able to negotiate that drug. But yeah, I mean, I guarantee you Medicare costs are not going to be going up 14% this year because Medicare has price controls. And it would be very easy to just negotiate these drug prices down, and then we wouldn't have to worry about all this shit. So
yeah, it feels kind of simple, right? It feels kind of simple. Hopefully, obviously Medicare for All would solve this problem entirely, but hopefully in the meantime, maybe more insurers will start covering the GLP-1s for weight loss, because it is important. Like I'm fat. I love being fat. My goal weight is something that most people would consider maybe a warning sign in their lives. But that being said, you can get into a situation where it's necessary to lose a little weight. And in those situations, you do, the boost is kind of wild that you get from these drugs. So anyway, not advertising the GLP-1s, but just saying that it would be cool if more and more people who find that they need these drugs had access to them.
Yeah, and people should not think of this just as an aesthetic cosmetic program. I mean, anyone with like back issues or, physical issues, weight can really make it harder to like manage other areas of pain. So I can imagine a whole range of folks for whom it would be really just very clearly medically important. So.
Absolutely. I mean, for me, I had like some hormone problems that were causing me to gain weight really rapidly, and I had a lot of mobility issues. I had difficulty walking, and it was a problem. So it was pretty necessary for me. Kind of, I want to say, like life-changing / life-saving. So again, if you need it, you should get it. So that's why people should cover it. So anyway, those are some exciting updates in the world of fat people healthcare.
I like that there's some semi-good news tucked in there for Medicare. So
yeah, okay. So now I was gonna save that for the end because I thought that was kind of good. But then I was like, no, we should just talk about the GLP-1s while we're talking about the GLP-1s. But the implication of the unfortunate consequence of that is that now we're going to end on Medicaid work requirements again.
Okay, so it's one of these podcast shit sandwiches where we start and end with bad news.
Yeah, probably not the best way to orchestrate this conversation, but whatever, we're here. So Medicaid work requirements are something obviously that we talked about a lot of times before, right? We covered last month when the federal rule came out. You'll recall that Congress legislated in 2026 that we would have work requirements for Medicaid, but folks weren't really quite sure how that was actually going to work until last month when the Center for Medicare and Medicaid sent out their rule that they have created to describe this. And as we described, it's kind of draconian and a little bit Dickensian, and all the, Kafkaesque, and all the words that you can find to describe this sort of thing. And so we know that a lot of people are going to lose access to Medicaid, and that a significant portion of them, that's in the millions, are going to lose access to Medicaid just because of the administrative churn of trying to verify, millions of people, trying to determine whether or not they have actually completed these work requirements. So, yeah. So last time we talked a little bit about it. We had talked about the way that we initially read the rule. It did seem like it was going to impact only states that are part of the ACA expansion. So, 41 states, after the Affordable Care Act was passed, decided to expand their Medicaid program so that it would cover people cover more people. And so the Trump administration wants to punish them for that. And so they are going to have to implement work requirements for those folks who are covered under their expansion. But I kind of wanted to do a clarification, because I found out this week that actually it's going to apply to even more folks than we thought.
Okay.
Yeah.
Who else is it hitting?
Okay. So I'm sorry, by the way, I think I said 41 states. I think 44 states, right?
Okay.
Including DC, have to deal with the Affordable Care Act expansion stuff. But I'm sorry, no, 41 states have expanded the ACA. The other states are actually dealing with this because, in addition to those ACA folks, enrollees in 1,115 waiver programs are actually being touched by this as well. So there are 3 additional states that are going to have to deal with this. And those are, Georgia, Tennessee, and Wisconsin. And that basically means that even if states that did not expand Medicaid are going to be implementing some work requirements going forward. Yeah.
I think what you meant there is the Section 1115 waiver. So this is the part of Medicaid where states can customize their Medicaid program.
Yes.
And even make it better. But and it's under Section 1115 of the Medicaid program. But then you have to negotiate with the federal government in order to, get your permission to deviate from the standard Medicaid program. So that makes sense. There must be states who have not expanded under the Medicaid under the ACA, but do have 1115 waiver arrangements, and that's how the federal government is getting them.
Well, that misreading was pretty embarrassing for me, but I'm glad you corrected me, Ben. But yeah, again, this stuff is complicated for a reason, and that's because they don't want you to understand it. So, yes, great. 1115 waiver programs. Regardless, this is going to affect people in these 3 non-expansion states. So you're not safe, even if you didn't participate in the expansion. So it's a real issue. And I just wanted to say that Arkansas, which is always ahead of the game when it comes to denying healthcare, they are actually doing a soft launch of this program already.
Isn't that what you call when you have a startup or a new restaurant?
Yeah.
You have a menu with friends and family events. We're just going to cut our friends and family from Medicaid and see how that goes first, and then we'll expand out to a broader audience.
I do like that idea, try this out with the people first, and then, we'll see how it works with strangers.
Kick grandma off and then go from there. Yeah, this is really ironic since Arkansas had the work requirement Medicaid law, whatever, back in 2018, that was a complete failure. It didn't accomplish anything. People did not gain work or work more. And the only people who were kicked off were all basically eligible, and a lot of them had jobs actually, but just failed to fill out the paperwork. I mean, that's the state where we have the most evidence that this is a dumb idea and it doesn't work in practice in the real world. But go Arkansas, short memory span. They've already forgotten 2018. So
They certainly have. I mean, and the Arkansas experiment with Medicaid work requirements was so shitty, if folks don't recall, that actually like 18,000 people lost their health insurance before a federal judge actually blocked the changes. So, and the Department of Health and Human Services is estimating that far more, so nearly 20% of those who are currently covered are going to lose health coverage after the new requirements go into effect, which is interesting because, well, as you said, right, they've had this failed experiment in this before. Also, in 2025, the Kaiser Family Foundation, which is where we go for a lot of our research, they actually reported that about 64% of adult Medicaid recipients in Arkansas specifically were already working. So not only does this not make sense because they've already failed at this before, but it also doesn't make sense because they have a pretty good percentage of people on Medicaid that are actually working already. So it's not like this is a pressing concern for them that they need to do an early soft launch. You know what I mean?
I'm sure this is going to go really, really well.
Yeah, I'm really excited for it. I mean, as you know, the governor there is Sarah Huckabee Sanders.
Oh, I forgot. That's right.
We remember her. She's part of the Huckabee political dynasty. She's Mike Huckabee's daughter. And then she also was Trump's PR person for a while until she got fired. And when she did get fired, I don't know whether you remember this, but Forbes, they actually published an editorial saying that companies should avoid hiring her because if they did, we would all know that everything their company said was a lie. So
I'd forgotten all about her. Thank you for reminding me.
You are welcome. I don't think any of us should forget about Sarah Huckabee Sanders. She's also the person who really jumped on the Medicaid cutbacks a few years ago. When the pandemic emergency situation ended, Arkansas was one of the first states to start cutting people from their Medicaid rolls too during the re-verification. So Arkansas, you are really, really making Texas look good. And I don't think that's a cute look for you. You know,
the home of Bill Clinton and bad health policy decisions.
Wow. And that's not a coincidence. Oh my. But aside from that, we're seeing a lot of Medicare for all back in electoral coverage. We've got, Axios just did a recent report on the spike of, candidates, insurgent candidates that are giving Medicare for all renewed attention. And it's coming back. It's coming back. And people are psyched. And we're just seeing a lot of really interesting primary victories of folks who are, fighting for Medicare for all and who are unabashed about it. Because for all the reasons that we've already mentioned in this podcast, people are fucking fed up.
Yeah, it's awesome. I kind of feel like this generation of new legislators is going to involve folks who have been around while Medicare for all has been a big issue for a while now. But, thinking back, whatever, 12 years ago to earlier election cycles, it's hard to find candidates who really knew Medicare for all and understood like the healthcare issues. But this is going to be like folks who have been a little bit dyed in the wool, I think, which is awesome. So.
Yeah, it's pretty awesome. We're loving it. And we're doing a lot of stuff to build on this attention that Medicare for All is getting, including, we've got a lot of stuff going on our on healthcare-now.org, where you can go and find out more about our No Surrender Summer. We are not giving up until we win Medicare for All. And we've got a bunch of different activities coming up, including a really big one for Medicare's birthday and another exciting thing that's actually going to be coming up in just a short while, which hopefully we'll be able to announce soon.
You've got a new podcast streaming platform.
Yes, hopefully it will be. Trust me, y'all will know when we're on a new platform because you'll actually be able to hear us.
On that note, it was lovely chatting with you, Jillian.
Yeah, it's been a pleasure, Ben. Really, really hoping that you have a slightly cooler week. Yeah, so now I want to show folks the interview that I did earlier this week with Diljeet, and so they can hear a little bit more about moral injury and why it's something that all of us need to care about.
All right, can't wait to see it. Bye, all.
Hello, everyone. I'm Jillian Mason, and I am very excited here to be with my dear friend from Physicians from a National Health Program, Diljeet Singh. She is a doctor, and she's here to talk a little bit about moral injury. And you might think moral injury, that's a term that sounds unfamiliar to me. But trust me, if you've been watching the Pitt, you know what moral injury is. They do a pretty good job, I think, of covering it there. So, Diljeet, let me do your thing. Let me give your bio, because I think that more people should be talking about how cool you are. So Diljeet is she's a women's health advocate. She's an integrative gynecologic oncologist, and she is also the president for Physicians for a National Health Program. She has a billion years of experience at places like Johns Hopkins and the MD Anderson Cancer Center. And she is super duper badass. And she's joining us from Canada today. So if she gets sick, she has access to healthcare. So we should all be jealous.
I'm just visiting Canada, just so nobody thinks that I've abandoned ship. I'm not ready yet to abandon ship. I'm here on vacation.
I'll believe that when you come back.
Jillian.
Sorry,
Jillian, for having me and for talking about this issue. Do you want me to just jump right into our study?
Yeah. Well, I mean, first, because do you think that the term moral injury, right, is something that might not be familiar to our audience? So do you think you could just go through what is moral injury and how do you guys define it for the purpose of the report? Yeah.
So moral injury in general comes from the military, and it came from when soldiers would come home from war or being deployed abroad or wherever, and they would have different versions of post-traumatic stress disorder, depression, other kind of manifestations of mental illness along this spectrum. And the people talking to them realized that there were these common themes to what they said. And the biggest theme there was betrayal, that they felt betrayed by their leadership because they felt they had done the wrong thing. And we started applying this. The nursing community applied this concept to healthcare. A couple good researchers and thought leaders, so to speak, Wendy Dean and Simon Talbot wrote about this now multiple years ago, applying this same concept to physicians feeling betrayed by a system where their hands were tied and they were unable to do the wrong thing. And so that's the definition that we use.
Unable to do the right. Yeah.
Physicians who are prevented from taking care of people, from doing the right thing for the people who are in front of them, and they are limited by hospital system, the health system, insurance companies, all of those things. Yeah. But they feel betrayed because they came into healthcare to take care of people. Nobody became a doctor in order to make money for United Healthcare. But ultimately, that's where we find ourselves now. And it's a million little cuts, so to speak. And then there's the huge thing of, so we did a study in moral injury using a survey tool that comes from the nursing research, where a great professor, Beth Epstein, a nursing professor from UVA, was looking at all kinds of health professionals at moral injury, but thinking about it more like moral injury within a team or a hospital, not thinking like moral injury that's related to the whole system. And of course, you might say, well, what does that mean, moral injury, like a team? We know that sometimes there's a family member who has a cancer diagnosis, and maybe the kids want something different for their parent than the spouse, and there's conflict between, what's the best way to take care of this person, and then being the healthcare person, whether it's being the nurse or the doctor, in that math can lead to a kind of moral injury. But one of the things that was never studied was sort of the bigger picture of how does the healthcare system itself cause moral injury.
I see what you're saying. So really it's like, a lot of the folks who have studied this before then are focusing more on like the kind of interpersonal, moral, emotional aspects of it, right? So it's like this one family made this decision, we had to carry it out, and that was traumatizing for us, right? Whereas you're saying, yeah.
And there's other layers even in the small world, like in a team where a doctor says, you think that, I think this, I'm the boss of this, so we're going to do what I say.
Sure.
And right, so there's that piece of in the team dysfunction that leads people to feel like they're doing the wrong thing. And we focused all on here. And of course, then the solutions, if you're focusing in here, is within here, right?
Yes.
If the problem is how the team interacts, well, we can fix that. We just fix the team. We improve communication. We set boundaries. We do whatever. And the really hard thing about healthcare system related moral injury is I, as an individual healthcare professional, cannot fix it. Right?
Yeah. This is not something that you can control by, fixing the interpersonal dynamics in your workplace, right? You can't just think about it different, right? It's
Right.
Yeah, that makes a lot of sense. Yeah.
Right. And the whole idea that, I don't know, it's so hard to, we were talking earlier about the relationship between burnout and moral injury and all of these things. And obviously they're interrelated, but anything that we talk about that's small area or individual related implies that I can fix it, right? If I'm burnt out because I don't take enough vacation, well, really, that's my problem. And I can fix it by taking more vacation or doing mindfulness meditation or doing more yoga or coming to Canada on vacation, right? Like those are all things that I could fix. On the other hand, if I have moral injury because I know when somebody comes in to see me that she should really get this drug, and this drug would help her symptoms or cure her cancer, but her health insurance company does not cover that. So I'm going to give her the second best thing. Yeah. And I know that the second best thing doesn't give us the best chance of treating her symptoms or curing her cancer. I kind of know I'm doing the wrong thing.
Yeah.
Right?
Yeah.
In cancer care, we talk about this all the time, about the time from having your first symptom of cancer to the time your cancer gets diagnosed. Now we know that's completely screwed, because now even like getting a CAT scan or just having a healthcare person, like being able to get into a clinic, may take weeks to months. Yeah. But we also know, like, if you're cancer, you get a biopsy that shows cancer on Monday, the sooner you get treated, the sooner you start your chemo, your surgery, your radiation, whatever it is, the better your chance of being cured. And now we just accept it. Like, we used to say, oh, we can get someone to the operating room within a week. We can get someone to the, see a specialist within 3 days, get them to the operating room within a week, done. Now we just accept, like, well, it might take you 3 weeks to get in to see a GYN oncologist. Well, it's going to take us, a bunch of phone calls to get your PET scan covered. And without your PET scan, we can't recommend, whether you should have radiation or surgery first. So we got to wait for that to come back. And you just know in your heart that every day delay, every week delay is giving that person less chance of cure. And they'll say, Dr. Singh, like, is it okay that I'm waiting this long? And it's so hard to say, well, one, I don't lie to my patients, but it's very hard to say, I don't think it's okay, but sorry, we're screwed. So when I say, I think you're doing the best you can, and this is the system we live in, and I have to leave it at that. Right. And that is, that's moral injury. And then, in our study, we did surveys, and then that led to interviews, and we used, all kinds of the results from the survey. We used some focus groups we did to design these interviews, and the stories that we heard right? Psychiatrists
Yeah. Yeah.
who knew how to treat schizophrenia, bipolar, whatever it might be. But they knew that the person they were taking care of here in the hospital did not have insurance. And
Yeah.
after 30
Yeah.
days, they would run out of meds. And they'd either be back or they wouldn't,
Yeah.
right?
Yeah.
They might
Yeah.
be back and come in, or they might commit suicide and be successful this time,
Yeah.
right? And the pain of that, of just saying like, I know the answer to this. I've taken the
Mm-hmm.
class, I've done my
Mm-hmm.
training, I've read the papers. This medication that we have, right? It's not like, oh, we haven't discovered the cure to this. We have discovered, and I just can't give it to this person.
Yeah, yeah. I wondered before we get into some of the stories from the report,
Yeah,
like every time I talk to doctors about this, and I really only started talking to doctors about this when you started talking about it on our national coalition calls, because I hadn't really thought about it from this angle. But every doctor I talk to about this has some kind of personal experience that gets them choked up about this, some kind of, so it feels to me like the kind of thing that you must develop an awareness of it pretty early on in your career, right? Maybe when you're a medical student or when you're first starting out. I wonder if you remember when you first kind of sensed this tension in your own career between what the system would let you do and what you were being trained to do and what you really wanted to do as a fucking decent person.
or even what you wanted to do, as in somebody trained you to do,
Yeah,
right? Like you got
absolutely.
educated to understand the time. So I I think it's very complicated. So, you know, within medicine, we take an oath. The day you
Right.
graduate med school, you take an oath, and that oath is multi-layered. And essentially, to me, it's I'm going to do the best I can with the knowledge I have to take care of people.
Mm-hmm. Mm-hmm.
And,
Mm-hmm.
there's all, the American Medical Association has a code of ethics. And in that code of ethics, there's all kinds of, you know, protection against the conflict of interest that might come up, right? And conflict of interest sounds like a very legal concept, but to me, it's like at the heart of what is causing moral injury. And that is,
Mm.
I want, when I'm sitting in a room with somebody, to know that everything I recommend to them is based on what's best for them, right?
Mm-hmm. Mm-hmm.
If somebody says to me, I'm done, I want to focus on my quality of life, I want it, then I take that into my mind. I think about what their symptoms are. Okay, these are the best ways to take care of your symptoms. These are the recommendations I make. But if somebody's like hanging over my head and saying, if you prescribe one more person OxyContin or this or that, like, our system's going to be challenged and we don't have that. Or you want a PET scan, you think that's the right thing for her, but you already ordered 5 PET scans this month and the radiologist are going to be pissed off or
Mm-hmm.
whatever, right? So now I'm making decisions with somebody else in mind. And then bring the insurance companies in who are like, no, we don't pay for that.
Yeah.
No, can't
Yeah.
have that. And, so it's hard for me to put my finger on it because I got involved in thinking about we should just have universal healthcare in America a long time ago.
Yeah, you were early to the game. Yeah.
But lots of people, we just didn't think through like what's the broken piece. Because the
Yeah.
other piece that's so important in America is capitalism, right?
Mm, mm,
Right?
mm.
Capitalism is part of our culture, being successful, making money, that organizations are driven to be blah blah successful, so this idea that the profit motive in healthcare, like, is it inherently immoral?
Yeah. Yeah. Yeah.
And I'm not going to get all semantic X about what's moral or immoral, but what I will say is there's a conflict of interest.
Great. Yeah.
You create a conflict of interest if I'm worried about an insurance company, about a hospital, about the, viability
Mm-hmm.
economically of my
Mm-hmm.
clinic or my office or paying my nurse practitioner or whatever it might be. But if I have to think about those thoughts and they're mixed into how I take care of somebody who's sitting in front of me, well, then she can't trust me necessarily. She
Yeah.
can't know that I'm just making recommendations for her, you know? And it's as
Yeah.
simple as like, you know, this whole argument about, you know, if you buy supplements, say, from your physician, and for some physicians, whether it's a supplement or it's a chemo or whatever, or if I'm a nephrologist and I earn money off the dialysis clinic, and then I always recommend dialysis instead of a transplant, well, that's because I had a conflict of interest, right? And, you know, I'm jumping ahead, but this is, of course, why I think the idea of Medicare for all makes sense. That if we
Right.
just take the profit motive out of healthcare, we eliminate that huge source of conflict of interest.
Yeah.
So then
Yeah.
between me and my patient and my staff and everybody in this business, we can just know everything we do is just to take care of people.
Yeah.
End of story.
Yeah.
Right?
Yeah.
So that conflict of interest, in some ways, I think a lot of physicians are trained to accept it. Like it's the way it is.
Yeah.
You
Yeah.
know, this is America and I got to take care of people. And so all I do is the best I can. And my hands are tied if they
Mhm.
can't. And I just have to take care of them when they're in front of my face. And I think some people can put on blinders and be okay with it. But the vast
Mhm.
majority of people that we talked to can't do that.
Yeah.
That it kills their soul a little bitty bit every single time they do it. And it makes them angry and all of these things. And, you know, is any amount of yoga or mindfulness meditation going to fix that? No, it
Yeah.
is not,
Yeah.
right?
Yeah. Yeah. I mean, that really does seem to, it brings me back to this issue of like, you know, the way the media frames this, right? Burnout, burnout, burnout. This is about burnout. This is basically, you know, it just makes it sound like, oh, doctors need a vacation, you know, doctors need to do the yoga, you know, take deep breaths or whatever. Like it does really just like kind of put it all back on you. And I wonder why you think that so many people are so willing to kind of accept this narrative, right? Of like, it's just about exhaustion. It's just about the personal, you know, the way you're personally managing it. It sounds like it has something to do with, you know, the kind of general displacement of like, this is a systemic problem, but we're going to put it back on the individual to avoid acknowledging the systemic problem. Is that kind of what I'm?
I mean, I think that's a huge part of it, Jillian. I think that the other piece of it, though, is, you know, none of us wants to psychoanalyze the medical profession, least of all me. But if I were to do a little
I
psychoanalysis
do.
of
I
us,
do.
well, I do think part of it is it's, you know, you want to be able to fix things. You were
Yeah.
trained to help people fix things. So, you know, thinking that, you know, you just sort of don't do the math on those. And then I will say these other things, and this may or may not be true, but I think we're trained to be experts of, right? I'm
Yeah.
an expert of ovarian cancer, so I can make good recommendations. I'm an expert of endometrial cancer. I trained in it for years. I keep up to it. I do my board certification for it. And a lot of physicians feel like they are not experts of healthcare policy and healthcare systems. And they like,
Yeah.
well, I'm going to leave that to the MBAs. I'm going to leave that to the execs. They understand this. And that's where I honestly think as physicians, we made a huge fucking mistake.
Yeah.
Because
Yeah.
the truth is, nobody else knows how long it takes to talk to somebody about their cancer recurrence and explain to them their issues. You know who knows? I know, because I've done
Mhm.
it for years and I've done it hundreds of times. I don't know, probably more than hundreds of times. But regardless, right? Like the idea that I'm going to like listen to somebody and they're going to tell me, oh, you know what, honey, it's going to take you 5 minutes to tell somebody that, you know, they have a limited lifespan and, you know, they should pick one of these chemos, right? Go listen to ChatGPT and then come back to me and tell me what you want. I mean, because, and so that need to be expert in,
Mhm.
and
Mhm.
that kind of training in our culture that
Yeah.
these are the people who know the answer to that. Oh, MBAs know how to run systems, or a health policy person, or I've got to listen to this executive. Like, all that is complete and utter bullshit. And we can't hand that over to somebody else to say, you know what, they know how to provide healthcare.
Yeah.
Now, and so I think there's that part of it. I think the other part is, you know, there's some things that it always feels more comfortable to feel like if there's a problem, the solution is within my capacity, right?
Yeah. Yeah. That's a real
Somebody has
human thing.
endometriosis,
Yeah.
right? It's a completely human thing. Like, to say,
Yeah.
like, what do I have control of? Let's make that the solution.
Mm-hmm.
But
Mm-hmm.
and people do feel helpless, and that's part of moral injury, right? There's the sense of betrayal, but there's also this helpless, hopeless, like, I cannot fix the healthcare system. I cannot oppose these insurance companies that have hundreds and hundreds and millions of dollars that they're making, that they're
Mm-hmm.
lobbying, that
Mm-hmm.
they're controlling, and then they're writing the articles, and the articles are saying, like, there's this, like, fucking complicated policy that's going to suddenly fix the system. And I just say, well, you know what? I'm an expert at endometrial cancer, so, you know, I'm just going to let the experts tell me. And the truth
Yeah.
is, those fucking experts are lying to us, and those experts are being paid by other people. And the experts are not sitting in front of patients who are suffering. They are not sitting in front of people who have pain. They are not
Yep.
sitting in front of people who can't get the things they need. We're doing that, right? Doctors are doing that. Nurses are doing that. Social workers
Mm-hmm.
are doing that. People inside hospitals are doing that. And I promise you, there's very, very, very few health executives who ever sit in front of somebody
Yeah.
who needs healthcare, right?
Yeah. 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 Unless we're there disrupting their shareholders meeting or something like that, which we need to do
Yeah, but
more of.
even then, they don't feel responsible for that person,
Mm-mm.
right? Like, because that's the other
Yeah.
piece of it, right? In healthcare, right? There's inherently it's, I always say it, like, providing healthcare is a moral endeavor, and
Mm-hmm.
at its heart is trust. The trust that that person puts in me when they show up in my office, the trust that that person puts in me when I take them to the operating room and they let someone put them to sleep while I try to fix them, right?
Mm-mm.
Like, that's trust.
Yeah. Yeah.
We put that kind of trust in United Healthcare. We put that kind of trust in Aetna. And it was the wrong place, because they are not fucking trustworthy. The people they think of first are their shareholders. The people they think of first are their executives. They do not think about patients first. And they stand behind this, like, oh, we have a fiduciary responsibility, blah, fucking blah.
Yeah.
Like,
Yeah. Yeah.
and the answer to that, some people have decided the answer to that is like, well, we can regulate the shit out of these people and make them be beholden to us. But the truth is, like, that's way more complicated, plus a waste of money, right?
Yeah, I mean, yeah, and it's really comes back to what you were saying before, right? This idea that we can't like just we can't regulate these folks because they are an inherent conflict of interest, right?
Yes, right.
Right? They just have a different agenda. For-profit companies, the insurance companies in general, they have a different agenda that is not compatible with the practice of medicine. Is that what I'm hearing correctly?
Absolutely, right? If providing healthcare costs money, and you make more money when you don't provide healthcare, well, then you don't provide healthcare. That's why they
Mhm,
have
mhm.
prior authorizations. That's why they have denials for things that should be approved.
Yeah.
That's why they stand in the way and create barriers to people getting the care they need,
Yeah.
right?
It's interesting too, because I feel like in some ways they've, just to get back to like how you guys compiled this report, I feel like
Mhm.
one of the ways that they sort of get away with this is by kind of training doctors into complacency, right? In terms of, you can't really speak about this in public. I think a lot of doctors that I've talked to in the past have been a little bit reluctant to tell their stories, right? Because they have a sense of, I'm not really quite sure, but you managed to interview these doctors and have them tell their stories And it really seems like to me like a kind of microcosm of the work you're always doing, right, at Physicians for a National Health Program, which is taking doctors who have these kind of ideas within themselves, right? Like I shouldn't be, this shouldn't be the way it is, and really getting them to actually speak up and speak out about it. And I kind of wondered, like how do you do that? Like how do you work with people to get them to the point where they feel they can speak up and tell their stories?
Sometimes you can't, right? If they've signed contracts, if they are worried that they won't even be able to provide healthcare if they speak out, and we've heard those stories, right? Of doctors who spoke out and then United Healthcare decided they weren't sending patients to their surgery center.
Right.
So I think that the reason people spoke to us because they were anonymous. It was a study and we did it anonymously and it allowed them to speak. And I think there is something very, very challenging there. For me personally, like I love doing this work as president of Physicians for National Health Program.
You better, because you do a lot of it. So.
but I really love taking care of patients.
Yeah.
So if somebody said to me, if you keep being president of PNHP, you can't take care of patients with gynecologic cancers, I would probably choose taking care of patients with gynecologic cancers and doing the best I could on a day-to-day basis, because that's actually like the one drives the other.
Yeah.
Right.
Yeah.
And I do think physicians, nurses find themselves where they don't want to lose their ability to do the job they love and were trained to do. And they don't want to have somebody say, well, so, you've spoken against United Healthcare, so anybody who has United Healthcare can't come to you. And there's a certain part of the population that you take care of that you won't be able to.
Yeah.
And so I think this silencing of physicians, truthfully, is another source of moral injury, right? To know in your heart that you know the right answer to this, but know that you can't talk about it because of whatever contract you've signed, whatever agreements you've made. I have left positions where I signed what's called a non-disparagement clause before I left. So I cannot speak specifically of the experiences I had there, that when I thought they might not have been doing the right thing. And that's just it. And I will say the other pieces, like most of us physicians, like try to do the right thing and try to follow the rules. And if I signed an agreement that says I'm not going to talk about X, Y, or Z, I don't, because that's giving my word, the same as I give my word to my patients that I'm going to do the best for them.
Yeah.
So this is, I think that the cost for people of speaking out is the other issue that comes up.
Yeah. So it is really important to give folks an opportunity to do what you've done in this survey and give them an opportunity to actually say these things out loud. Do you find that then once folks have said it out loud, then they're more likely to be willing to take action?
I think there's a spectrum. It depends on where you are in career. It depends on, what you're doing. I've been in practice for 26 years, 27 years, and I have some flexibility to the ways that I can provide care. I am a subspecialist. We really need us. And so I might have a little bit more flexibility than someone who just starts out and doesn't have a proven track record and are still trying to, build a reputation within their specialty. And so do I think people are more willing to speak out? I think people do what they can do. Maybe it means doing research, right? And for many of us, like research is a more comfortable way, right? That you're making an argument, you're proving something. We were lucky that the Robert Wood Johnson Foundation funded this work for us to be able to do it. For other people, they may donate to an organization. They may get more engaged in using the power of their vote. Right?
Sure. Like at the AMA or
or at the good old ballot box when they
sure thing, yeah.
when they vote for their congressperson or their senator or the president of the United States, right? So there's different ways that when we talk to people, they get empowered. I think the very challenging thing for me is many people sort of leave medicine And we saw that
Yeah.
over and over, that 20% of people have recently left a position, or are another 20 to 40% are thinking about leaving positions, but that there's this sense that maybe I can find the right thing. And I do think, people talk about, like, why do so many doctors have these concierge practices? Are they just trying to make more money? Most often they're trying to create an environment where they can just control it. They
Yeah.
can,
Yeah.
find a way that, well, I'll find you a cheap place to get blood work that you can get blood work, and I will try to create a mix. One of the docs who I spent a long time talking to, who actually has gotten engaged with PNHP, no names because it was an anonymous, but regardless, like, he was working in an area where he and his group bent over backwards trying to figure out how in this area, the rural area of the country, can we provide healthcare to people. Like, what if we create our own system, and what
Mhm.
if we start using this lab instead of this lab, and what if blah blah blah. And ultimately what they figured out was, it really is just too hard.
Yeah.
It's
Yeah.
too complicated. Medications are too expensive. Maybe you can provide primary care, but the second somebody needs an operation and they need an anesthesiologist and a hospital, well, then they're not going to be able to pay for that, because that cost is astronomical. It's like not even a real number.
Yeah. Yeah.
Right.
Yeah.
And so, yeah, I don't know if that quite answered your question.
No, I mean, yeah, I mean, it feels like it's all super interconnected. And yeah, I mean, pointing out the systemic causes of mental health issues is really interesting, because it does place a greater obligation on us as a society, and probably on doctors as a profession, to speak up about what's going on and to make systemic changes. And
Yeah. Well, and the thing is, you're not broken if you're feeling moral injury. You're
yeah,
actually intact. You're doing your job as a physician. You're trying to maintain that oath that you made to your patients to provide
yeah,
them the best care, to put their needs above the needs of a corporation, to put their needs above any other entity, right? So you're fixed, you're intact if you're having
yeah.
moral injury, right? Isn't that kind of bizarre? But that's our
Yeah.
system.
No, right. This is kind of like the "you're not crazy, the world is crazy" kind of
Hmm.
like, this is the system is crazy. And, this is, but, we go through this a lot actually when we talk with patients and ask them to stand up and tell their stories, right? A lot of folks have internalized this idea that, like, if I have health problems and I can't pay for it, that's my bad, like I should have gotten a better
Yes.
job. I should have gone to whatever. And so, yeah, like getting people to see that, like, no, this isn't a you problem. This is an us problem. This is a systemic problem. You are not failing. The system is failing you.
And I'm like not I believe in capitalism for cell phones. I love my certain headphones, right? Where I think yeah, you want to compete, go compete, right? Because you can come up with a $10 cell phone, and you can come up with $1,000 cell phone, and this
Sure,
many bells and
sure.
whistles, and this many not bells and whistles, and let's give everybody a bunch of options and all that kind of thing. The problem is, healthcare is not that kind of product,
Mhm,
right?
mhm,
Number one,
mhm.
everybody needs it. And so it can't be something. And, you know, choosing the least bells and whistles, that's not how you choose how you get your healthcare, right? If you
No.
have if you have complicated ovarian cancer and you need immunotherapy, then you need immunotherapy. You need the latest drug. If you need robotic surgery, you need robotic surgery. You can't choose a less expensive option,
Mm-mm. Yeah,
right? And
yeah.
so this idea that education, healthcare, you know, firefighting services, that police, that there should be some things in our society that are covered for everybody. And then there's other things like, you want to spend $3,000 on an evening dress? Go for it. You want to spend $5 on an evening dress? Go for it. Do I think our society should provide both of those things? Sure.
Mhm,
But
mhm.
I don't think healthcare should be a for-profit business, period.
Yeah.
And that very idea of it's a moral endeavor built on trust means we just got to take that like that conflict of interest out. And it's as simple in a way as that.
Yeah.
Is, you know, we can talk about the economic reasons we should take that profit motive out because it's a waste of money, right?
Sure.
In America, if we got that 30 cents of every dollar right now that go to profit and administration, and probably it's more like 50 cents. It's hard to do the studies now that private equity is in the mix. But if we took that money back, we could give it to everybody. We could do dental, we could do vision, we could do true mental health care. So there's that economic argument about it. But I also think this very basic idea of like, no, you just need to take conflict of interest out.
Yeah. Yeah.
Because go ahead.
Oh, I was just going to say that, like, you guys are fighting for Medicare for all, as are we. And so can you tell me more about, just to wrap up here, what would it look like if we had a Medicare for all system? How would this issue of moral injury be different for physicians? And how would that translate to a difference for patients?
If I never had to worry about whether something was covered or not, if I just could have somebody come in my office, they had X cancer, I knew what the right treatment was, they felt like they wanted to get that treatment, and we could just sign, seal, delivered, and do it. Right? If everybody in America had access to healthcare, if we used medical society review of the science and the literature to help us make decisions and make recommendations, not what does their insurance cover? No, what's the right thing? What does science tell us? Right? That whole aspect of moral injury would go away. Now, are there still going to be difficulties? Are there still going to be situations where a patient's spouse wants them to do one thing and their kids want them to do another, and you feel conflict because, that's something hard for them to work out? For sure. Right? And are there going to be days when I say, I think chemotherapy is the best thing for you, and someone says, well, I think you should do surgery first because of this research, and the research isn't black or white? Yeah, there might be conflict, but the basic idea that I don't have to worry about it. I don't have to worry about, are they going to have access or not?
Yeah.
And I think the other piece that it will fix is, I've worked in all different I worked in Green Bay, I worked in Roanoke, I worked in places where people really had to travel to see a specialist like me.
Yeah.
And it was because hospitals are built in places where they can make the most money, not where patients need them. And if we had Medicare for all, and we could make decisions based on, hey, this is the population in this area, this is what they need. Hey, this is the farming population, they need a trauma center, and they need something they can get to because they work with big old pieces of equipment and stuff. Now I'm talking outside my specialty, but regardless, like if we could make decisions based on like what we need, not what makes us money.
Yeah.
Right.
Yeah. I can see how that would change. I can see how that would change the experience of doing your job and also the experience of being a patient, right? Like, because when doctors are allowed to be doctors, right, then patients are allowed to be patients instead of constantly. I mean, when I go to the doctor's office, I'm constantly second guessing. Are you saying that because it's the right thing to do? Or are you saying that because it's, the cheap thing to do? Are you saying it because that's the thing that's, and it really corrupts the relationship between doctor and patient. So yeah. So
that's why I think like that other piece, we haven't even talked about the lack of trust in science and healthcare in America.
Absolutely.
But this is why people don't trust us, because if I'm making decisions based on what United Healthcare wants, I am not trustworthy, right? And like I said, like there is a certain complexity to telling patients, well, this would really be the best thing, but your insurance doesn't cover it. So sorry, so sad, right? Like that's just not my style. But the truth is, like, I have found myself like telling people that because they deserve to know. They deserve to know what's limiting their access. No, I think that, am I surprised that people don't trust pharmaceutical companies? Pharmaceutical companies are not trustworthy. Am I surprised that people might be worried that when I recommend they get X, Y, or Z, that they might worry, like, I wonder if Dr. Singh's getting a cut of that? I wonder if Dr.
Yep,
Singh wants to do that so she could put her kid through college, right? And and they're not wrong. And so I think that's what becomes really hard. And I think that's what makes it really easy then to read a book where somebody's like, well, if you just eat mashed potatoes and blah, 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 you're going to cure your cancer, or you take ivermectin, or you do whatever the hell, you just fast,
Sure.
and be like, well, I just bought the book. That person, like, maybe I'm going to trust that. Maybe it's equally trustworthy. Or my cousin said they did it, and I trust my cousin, and it works for her, right? I mean, and so we find ourselves in this place where because we allow these conflicts of interest to exist, we have made it impossible to trust healthcare. We have made it hard to believe science, right? And that's a whole nother piece that we have to fix. But the first way to fix this is to make profit-free healthcare available to everybody in America. No copays, no deductibles, no prior authorizations, no medical debt, none of that shit, right? You get the healthcare you need when you need it. You get the preventive healthcare you need, so you never end up needing X, Y, or Z, right? I think it's relatively straightforward. I think when we come up with these very complicated regulations and plans, like, stop. Healthcare for everybody. Listen to the science. Let the American Academy of Pediatrics really look at all and tell us what vaccines make sense, what are the risks, what we should do.
Absolutely. Absolutely. All right. Let doctors do the doctoring, get insurance companies out of it, and let patients actually get the healthcare they deserve. That sounds like a great plan to me. And I thank you so much for all the work that you're doing and all the works that all the folks at PNHP are doing to make that happen. And I just really appreciate all the organizing that y'all do. We'll make sure to drop in the show notes the link to the specific report. What's the title of that report again?
Moral injury. And you can go to pnhp.org and I know, we're simple people. And find that report and find the other work we're doing. And we at PNHP are so thankful for all of the groups that are doing this work. Y'all at Healthcare Now, NNU, National Nurses United, the work that Public Citizen is doing, the work that Social Security Works is doing, all of these organizations that are trying to get healthcare for everyone in America. We're happy to be working with you, and we're happy that this is something that we are finally pushing our politicians on. Right?
Yeah. And the more of us who can get together and do that, the closer we are to winning. And that's amazing. So I want to thank you so much for being here. I also want to thank our podcast team, especially our audio editor, Craig Stanton, who edits out all the ums and ahs. And I would like to remind you all to like, subscribe, comment, and share with your friends. Help us get the word out there. I also want to remind you that this podcast is a project of the Healthcare Now Education Fund, and you can support the pod by going to www.healthcare-now.org and clicking on the donate tab to send us a little love. Thank you so much, everyone. Thank you so much, Diljeet. And everybody stay safe and stay dangerous.